cord injury. I guess we're recording now. Spinal cord injury and contraception. And we're very fortunate to have two speakers to us. Yang Wang is a fellow at Queen's University in contraceptive advice, research, and education. And with him is the director of that CARE Fellow program, Dr. Ashley Waddington, who is an assistant professor in OBGYN at Queen's University. She has a number of, she herself completed that CARE Fellowship. She also has completed a Master's of Public Administration, is co-director of the CARE Fellowship since 2014. She founded the Complications of Early Pregnancy Clinic in Kingston and the Transgender Clinic as well. She's medical director of the Women's Clinic at Kingston General and medical director of the Sexual Assault and Domestic Violence Program in Kingston. She has a number of areas of interest, including family planning and transgender healthcare. So without further ado, I'd like to turn it over to our speakers today. And please use the chat if you wish. They will be monitoring it, and we want this to be interactive. So if you have questions, comments, suggestions, please put them in the chat, and I believe our speakers are going to be responsive to it. Thank you.
Oh, perfect. Thank you so much for the introduction, Dr. Lee. As mentioned, my name is Yuyang Wang. I'm the current CARE Fellow here at Queen's University. I did my residency in OBGYN in Halifax at Dalhousie University and did my medical school at the University of Western Ontario when it was still known as the University of Western Ontario. I believe it's just called Western University now. But without further ado, we'll talk about a very interesting subject today called spinal cord injury and contraception. So to begin with, for any discussion in regards to research previously done in individuals with spinal cord injury disability, we always have to acknowledge the previous bias that had occurred in the sciences and medicine and research that took place previously in regards to sexuality in patients with disabilities overall. The health of individuals is often assessed in terms of parameters of able-bodied individuals' health. And this assessment may not always may not always have the validity in terms of gender-based knowledge, and also may lack a disability-based focus. So any research involving individuals with disability often ignore this sort of gender aspect, which includes sexuality and sexual health. There's often quite a bit of neglect, especially in discussion in regards to sexuality in women with SCI. And when I speak of women, I always refer to the born sex of the patient. There's little discrimination between sexes in research based focused on disability, and any data is mostly focused on the needs of men with spinal cord injury, and there's always a lacking of discussion regarding women's health for spinal cord injury. And women with disability are often not seen as whole and seen as defective or asexual. Sorry, I'm just letting this overhead announcement go. So often this topic of sexuality and contraception is frequently neglected. So that being said, we sort of focus on reproductive health overall, and knowing that there is a lack in this area where there's both physical and provider-based biases for ability of adequate health in this patient population, where there's a lack of care in cancer screening, especially in cervical cancer screening, STI screening, contraception discussion, prenatal counseling, and menstrual management. And ultimately, it is the responsibility of all providers to recognize that these barriers and biases exist when providing for care with individuals with disability. So when we talk about contraception in spinal cord injury, we should talk about that the misconception that women with spinal cord injury are often seen as asexual, and that's not the case. Majority of women still engage in intercourse, mainly penetrative intercourse. Therefore, it is important not to neglect this conversation of contraception when seeing these individuals of health. Of course, the level of sexual interaction is really dependent on the level of disability. With higher the spinal cord injury, the less likely an individual is to participate in intercourse. However, the vast majority of individuals with SCI still engage in intercourse. And previous data, especially qualitative data, have shown that among sexually active women with spinal cord injury, only about 70% of women were using some form of contraception. And this is really speaking to a bias that occurs when discussing this. And also, there is also different aspect of reasons for why these individuals are not using contraception, whether it be pregnancy planning, frequency of intercourse, or overall just a lack of knowledge of availability of different contraceptive methods. In terms of different methods, we can see that condom use or barrier contraception is the most frequently used form of contraception, followed by sterilization. So in this case, it would be tubal ligation or self-injectomy, where we're removing the fallopian tubes completely, or hysterectomy, and vasectomy as well. And then lastly, birth control pills, so combined hormonal contraceptive are used. So some general considerations for contraception in SCI from the American Spinal Injury Association, so ASIA. This is their newest guideline from 2020 and builds upon what previous research has been done. So these are the overall outlines that they have in regards to contraception in SCI. So choice of contraception should depend on status, circulations in the leg, history of VTE, genital sensation, manual dexterity, and menstrual hygiene needs. And the only real sort of relative contraindications they talk about is the avoidance of use of combined hormonal contraception, whether that be oral, transdermal patch, vaginal ring. Avoid the use in women who are less than 1 year out from their spinal cord injury, in those who are smoking, in those with a history of cardiovascular disease or have circulatory problems. But overall, I think the biggest takeaway message from this, and I'll go through this with the rest of the presentation, is that the risk of hormonal contraceptive use in SCI is no greater than the general population. So that is a big takeaway from this presentation. So again, general considerations, again, just a little bit. About the majority of women will have resumption of menstruation after spinal cord injury, but there is a high rate of secondary amenorrhea or a lack of menstrual bleeding after the initial spinal cord injury. So about 50% of women will resume menses within 3 to 6 months, and then over time, the majority will have resumption of menstruation. So this fertility aspect is still needed to be addressed when seeing patients even early on. And things to always discuss when talking about contraception in the SCI population is to assess what other concomitant medications are being used, their bone mineral density and risk of fracture based on medication use, other patient factors, their patient's overall mobility and their disability. And lastly, big broad takeaway as well, this should be bolded, progesterone-based hormone contraception have minimal risk of VTE or venous thrombotic events. So that is something, a big takeaway as well from this talk. In terms of drug interaction, this is from the CDC MEC criteria or medical eligibility criteria. And I just wanted to talk about mostly that there needs to be a good discussion in regards to and a good thorough history about what type of medications the patients are taking. The main ones to focus on is the anticonvulsant therapy use, especially with patients who have a history of epilepsy, or some patients use anticonvulsants as a mean of as a treatment for neuropathic pain. So this is the category that will most often push combined hormone contraception and even oral progesterone-based contraception into the category 3s, and category 3 being that the relative or theoretical risk of harm may outweigh the benefits. So a thorough discussion needs to be had. And most often, just sort of in broad strokes, what we know is lamotrigine therapy as a monotherapy decreases the effectiveness the effectiveness of lamotrigine as a monotherapy is decreased when you are using oral combined contraception. So there's an increase in seizure activity when you are using lamotrigine and oral combined hormone contraception. And then when you're using other anticonvulsants, such as like phenytoin, carbamazepine, or barbiturates, those anticonvulsants decrease the efficacy of combined oral contraception. So there's an increase in pregnancy risk. How much other formulations like the patch and the ring interacts with anticonvulsants, it's unclear. There's not a lot of good data regarding what is effective, what's the medication interactions. And then I put down this link down below. It's from Epilepsy UK, and they have a really good description of every anti-epileptic medications and its interactions with different forms of contraception and what are the potential interactions. And I found it quite useful when I was doing the preparation for this presentation, and it's a good resource to go to. So on the right here, or on my screen right, is the WHO tiered effectiveness for contraceptive effectiveness, depending, and from the bottom and goes up. So bottom is least effective, top is most effective. I'm sure a lot of people have seen this. When I have a discussion with my patients in regards to contraception, I always ask these two questions: is when and if does an individual ever want to become pregnant, and how important it is for those individuals to not be pregnant until they are ready. And that will help sort of build or start a discussion around what is the most appropriate form of contraception for these patients, or what they would like to use. And then additional question I've been starting to ask is how important it is for you to have a regular menstrual bleed, or subsequent is how important it is for you to not have a regular bleed. And that will help me also dictate what are some viable options for those patients as well. When you talk about effectiveness, so the most effective methods would be the ones that results in less than 1 pregnancy per 100 women in 1 year. So that would be sort of your top row with the implant, IUD, and surgical methods. And then the least effective would be those that results in 30 or more pregnancies per 100 women in 1 year. So those are, you're looking at the bottom tiers. So your fertility awareness, your spermicide, your barrier contraception. And I think the discussion regarding menstrual suppression is pretty important, especially in women with disability, because hygiene can be quite a challenge to this patient population. So this is something important to add when talking about contraception, because a lot of these contraception methods offer that benefit of being amenorrheic or reducing heavy bleeding that some patients would find quite beneficial. So in regards to contraceptive methods, we'll go from least to most effective. So this is the natural family planning methods. So these are, there's 2 ways. Number 1 would be the fertility awareness-based methods. And the short form is called FAB, basically. And it relies on the knowledge that all conceptions arise from intercourse occurring from 5 days before to 1 day after ovulation, and then to avoid intercourse during this window of ovulation. And how do individuals keep track is basically they have to have regular, predictable menstrual periods, or whether it be by symptoms or whether it be by calendar. And some patients are aware of their fertility because they analyze their cervical mucus, they do their basal body temperature testing, they use standard days method where they kind of have a prediction calculation. This, by most society, is a not recommended method because cervical mucus assessment can be quite challenging in those who are disabled and can't access their cervical mucus. And secondly, there is a change in basal body temperature in those with SCI. And then as well, decreasing sensation. Some patients are no longer aware of their consensus ovulation. So something like middle smirch, they're not aware of ovulatory pain. So overall, this is not a recommended method because it's not a reliable method in this patient population. Fertility monitoring is another option in which there's ovulation predictor kits, where you use the saliva, a urine to assess the LH levels for when ovulation may or has occurred. And there's also an electronic method as well. These methods are good to indicate when ovulation has passed. So once your LH, which is a hormone that is signaling between your brain and to your ovaries, when that level has spiked, that's an indication that you have had ovulated. So it's not always the best predictor of when you may ovulate. It's more of a predictor of when you have ovulated. Withdrawal methods, so it's avoiding of any male semen ejaculation into the vagina or onto the vulva. Again, not always the most reliable method because there are sperm present in pre-ejaculate fluid as well. So it's not a good method for avoiding pregnancy. So pros and cons. So pros, you're avoiding any risk associated with hormone contraception. So all the side effects associated, all of the risk of VTE associated with the combined methods. As well, you can augment any of the other methods like barrier, and you can use it in conjunction with a natural family planning. The cons, there's a very high failure rate, about 20 to 30% pregnancy rate in 1 year of use. So high failure rate leads to pregnancy, and pregnancy for some patients with a disability and injuries is quite dangerous. So that is a big con. Low continuation rate. Cost, I put down the cost because the ovulation predictor kits are quite expensive and not covered by drug plans. Need to adhere to a strict abstinence timeframe. So you're really having to avoid the ovulation window. And again, may not be able to predict or monitor signs of fertility as well in this patient population. Next, we're going on to the barrier contraception. So this includes male and female hormones, cervical caps, diaphragms, vaginal sponges, and spermicide. So as a whole, this group forms basically exactly what it sounds like, a barrier to preventing the contact of sperm inseminating into the uterus and subsequent onwards in fertilization. Pros. It's readily accessible. So condom is the preferred method for most patients with spinal cord injury. There is no risk of medication interaction, with the caveat of latex in sensitivity. I'll talk about that in a little bit. It can be used on an as needed basis. And again, you're avoiding the risk associated with hormone contraception. The downside would be for a lot of these, especially the female barrier methods, the female condom, the cervical cap, diaphragm sponges, you do require some level of manual dexterity to insert the devices. And as well, changes in pelvic floor tone, pelvic floor structure after a spinal cord injury may prevent the use of these barrier methods, because the diaphragm or the cervical cap, you need to have good pelvic tone in order to maintain it in a good position. So not having that tone can sort of be prevents its use. There is a increased risk of PID and urogenital infections, especially when you're including this patient populations who are already at risk for urinary tract infection because of their increased need for catheterization or indwelling catheters, right? Failure rate. So failure rate is quite high, about 10 to 20% depending on the device. I'm going to make the caveat here in bold, there's no spermicidal jelly available in Canada, and that 10 to 20% failure rate is quoted with use of spermicidal jelly, whether that be the diaphragm, the cervical cap. The previous research is based on using those barrier methods with the spermicidal jelly. So we don't know what, if at all, those barrier methods, whether they're effective at all without spermicide. So I assume they're probably going to be higher as well if we don't have spermicide available in Canada. Latex sensitivity. So patients who have history of spina bifida, they are at increased risk of severe anaphylaxis and subsequent severe mortality risk from latex exposure. So that is something you need to be cognizant of because some of those products are going to be latex based. Moving forward, I think I touched on most of these, requires commitment and teaching. So despite my discussion here, even though it is not always the best method, if this is what patients want to use, and this is the only method that's appropriate, they want to try, then it is still something they need to be counseled on. And partner education is important in this situation because the partner can be quite helpful in terms of insertion and removal of these devices. It's important not to dismiss these methods based on just physical limitations alone. And we talked about the latex allergies already. Moving forward, we're going to talk about combined hormone contraception. So that includes the oral contraceptive pill, the transdermal patch, which is a weekly replacement, the vaginal patch, the vaginal ring, which is a monthly replacement or every 3 weeks. Their mechanism of action is through inhibition of ovulation. So the overall risks of hormone contraceptive use in SCI are no greater than the general population. So that is something that I'll keep hammering. But you need to take into consideration mobility and other risk factors for VTE and medication interactions when we're talking about the use of any of these combined hormone contraceptive use. And as well, I talked about already, you need to consider the non-contraceptive benefits. So what are those non-contraceptive benefits? Improvement in dysmenorrhea. Depending on the level of spinal cord injury, some patients might not have any dysmenorrhea at all, but it is still an important consideration. It can reduce heavy menstrual bleeding, or if you're using it in a continuous or extended form, it can suppress or it can provide menstrual suppression. So this could be of great benefit for patients who find menstrual hygiene quite challenging. Use can also have a decrease in the ovarian endometrial cancer risk. And then it's effective, it's discreet. And there's various routes of administration. We talked about the drug interactions already, especially the anticonvulsants. So that's something to be aware of. Risk of VT and mobility, I'll touch on that a little bit, but that is always something that a lot of people are very hesitant about when prescribing combined hormonal contraception. Maintaining a schedule and troubleshooting error. So being able to stay on top of medication use on a daily basis, being able, or on a weekly or a monthly basis, depending on the formulation, knowing what to do if you miss a pill, knowing what to do when your patch falls off, or you keep the patch on for too long, or the ring, if you get the ring is in there, that is a con for a lot of patients. And ability to use the vaginal ring. Again, we talked about the change in pelvic floor tone, so the vaginal ring may not be something that all patients can use. When we talk about combined hormone contraception and VTE, so overall, all comers, the general risk of VTE is 4 to 5 per 10,000 women years. So that's kind of a weird metric, but it is a low event. So it's a low, it's a very small patient population, right? And the risk of PE risk is about 1.6 per 10,000 women years. When we're comparing it to all use of combined hormonal contraception, that risk is increased to basically doubled. So 10 per 10,000 women years. And then PE risk is also doubled as well. Relative risk increase, yes, there is a relative increase, but absolute risk is still low. And then when you're comparing that risk, let's say comparing it to the relative risk of VTE, in pregnancy, it's going to be a much higher number than combined hormonal contraception. You're looking at a relative risk increase of 6.7, and in the postpartum setting, it's 115.1 versus general population. So yes, you have an elevated risk of getting VTE and PE with use of combined hormone contraception, but you gotta weigh that risk of the patient getting pregnant, and then their risk of VTE is going to be so much higher when pregnant or in the postpartum setting. And then overall, there has been no documented for the general population using combined contraception, no risk of arterial thrombosis, MI, stroke with use of combined with less than 50 micrograms of ethinyl estradiol. There's no Canadian products available with greater than 50 micrograms of ethinyl estradiol. So when we talked about CDC and the MEC, immobility is not an absolute contraindication to use of combined hormonal contraception. Immobility, in addition to certain other risk factors, will push combined hormonal contraception into a level 3 or level 4. So combined hormonal contraception use in the setting of breastfeeding when you're 21 to 42 days, that's going to be a MEC class 4. major surgery with prolonged immobilization, that's going to be a class 4. Multiple sclerosis, that is going to be a class 3. However, I'm going to point out, this is a quote from the CDC itself. There is no data. There is no data to what is the actual risk increase for VTE among women who are immobilized with multiple sclerosis when they're using combined hormone contraception. It is a theoretical risk because the risk they know from MS is that these women are higher as well. So 2 and 2 combined together will push this into a category 3. And this is what we see. Category 3 with MS with prolonged immobility. Overall takeaway, though, it's going to be, there is not a lot of data. This is going to be a sort of a theoretical or predicted risk, but what data is available shows that women who have SCI are at no greater risk of VTE when using combined hormonal contraception from what available data is showing. But again, something to be cognizant of when you're counseling your patients in regards to that point. Lower limb sensation might be lost because therefore you need to really talk about the other signs and symptoms of VTE as well. So something to prepare patients for. Progesterone-only contraception. So this is a broad category, includes the progesterone-only oral pills, Depo-Provera or depo-medroxyprogesterone acetate, hormonal IUD, subdermal implants. There is no increased risk of VTE with use of progesterone-based contraception in this population. In bold here, the major downside for any progesterone-based contraception is going to be irregular bleeding pattern when you're initiating the use or with continuation of use. So hygiene for some patients may be affected with these use, and that can impact the quality of life for your patients. Progesterone only pills. So previously it's the Micronar, so that's off the market now. It's only the generic version, which is Movies, which is norethindrone 35 milligrams daily. The mechanism of action is through a change in cervical mucus to prevent sperm penetration. So it is not it does not inhibit ovulation. And it can be safely used in patients even with an increased risk of VTE. So we use it in postpartum setting, people who have prior history of VTE, it can be safely used in that regard. A major downside is that there is a very small window of daily use. So you have to be able to take it within 3 hours every single day. And if you're missing it, then the effectiveness of the pill is going to be decreased. Irregular bleeding patterns we talk about. There is some discussion about the androgenic side effects because norethindrone is a first generation progesterone. So there is going to be some androgen component, but the data is not the greatest in regards to this. So it's not something I always talk about. Increased risk of ectopic pregnancies if there is a failure with this use. And that's partially because that there is some, it does affect the ability of the fallopian tubes to transport the fertilized embryo down into the uterus, and that's affected by the progesterone. So there is a theoretical risk or a higher risk of ectopic pregnancies if a patient does become pregnant. Pros though, very few patients have true contraindications to the oral progesterone method, and there are going to be still non-contraceptive benefits: improvement in dysmenorrhea, improvement in heavy menstrual bleeding, improvement in pelvic pain. There is no pill-free interval. You don't have to worry about skipping weeks. You don't have to worry about withdrawal bleeds. You just keep taking it every single day. And then again, no increased risk of VTE, which is going to be the same for all classes of progesterone. Next up is going to be the Depo-Provera. It's something that it's very readily used, and it's an older form of contraception. It's an injectable progestin-only contraceptive. It can be used as a subcutaneous injection. It's not available in Canada, or an intramuscular injection, and that's what we use here in Canada. Intramuscular is 150 milligrams every 3 months. It suppresses ovulation. So major pros is going to be low maintenance, it's reliable, it's reversible, it's discreet, it's very effective as a contraceptive. And there's a high rate of improvement in dysmenorrhea, improvement in heavy menstrual bleeding, and there is a high amenorrhea rate. So from the SOGC guideline, which is the OBGYN guideline, they quote about 50% of users achieve amenorrhea after 12 months of use, and that goes up to 70% at 2 years. So pretty high rate of amenorrhea. From depot, we also know that there's an increase in seizure threshold. So I actually use this as a way of treating patients with catamenial seizures, or seizures around the time of menstrual bleed. That's the effect of progesterone. There's a reduction of PMS symptoms, and there's an overall decrease in ovarian cancer risk as well. So those are a lot of benefits to this. And again, no increased risk of VTE. The cons is going to be abnormal bleeding pattern with all progesterone use, weight gain, and I'll talk about that a little bit in the next slides. Decreased bone marrow density, I'll talk about that, and some hormonal side effects. I commonly hear about breast pain, bloating, some mood changes, but most of the patients, it improves with longer use. So if patients can stick with it, a lot of these side effects will go away or get less. And delay in return to fertility. So there is a washout period in terms of if a patient plans to try to get pregnant, but fertility, it will resume, but it is going to be delayed, and that's quite variable for the patient. In terms of bone mineral density, what we know is that there's a transient and reversible decrease in bone mineral density with use, and the greatest loss is in the first 1 to 2 years of use. The loss of bone mineral density in adults and adolescents is never less than 1 standard deviation of normal. And that is well below the cutoff of what we consider osteoporosis, which is that you have to be below 2.5 standard deviations of normal for it to be considered osteoporosis. So there is no increased fracture risk of using progesterone, of using Depo-Provera, but there is a hit in bone mineral density that will return after 2 years of continuation. So that is a recoverable bone mineral density. So I use this quite often in my adolescent younger population as well. And I think I counsel extensively about using calcium and vitamin D supplementation, doing weight-bearing exercise, which may or may not be an option for patients with spinal cord injury. There is no conclusive evidence that Depo causes osteoporosis. There's no conclusive evidence that increases fracture risk. So that's something I can reassure most patients when I'm using this for them. And then I also counsel about the other things that are known to decrease bone mineral density risk. So caffeine intake, smoking, sedentary lifestyle. So those are all things that I counsel on to help buff up that bone mineral density. From the guideline, so from the Asia guideline in 2020, they do have a big cautionary, they put a big cautionary spin about using Depo-Provera, in which, yes, DMPA does cause a hypoestrogenic state because you're inhibiting ovulation. Thus, in turn, patients with spinal cord injury who are chronically immobilized, there are at increased risk of compounding increased existing bone fragility. So they are a little bit hesitant about using Depo-Provera, but there's a recent study published last year where they did a chart review of 100 patients with cerebral palsy who were wheelchair or have a decrease in mobility, and they found that those who with cerebral palsy and with decreased mobility who use DMPA, when they compare the bone mineral density to those who were never exposed to DMPA, their bone mineral density were exactly the same. So there was no difference between the two. So that's reassuring data that DMPA can be safely used in this setting. Weight gain. This is something I hear about quite often for patients who are wondering about DMPA. So there is really no good evidence that DMPA causes weight gain. So from the product monograph, from their clinical trials, they show roughly a 2.5 kilogram change in the first year, or roughly 4 kilogram change in 2 years, and then roughly 6 to 7 kilogram change in upwards of 4 years. But from Cochrane review, from meta-analysis, they show that overall, there's less than 2 kilograms weight gain over 12 months of use for the patients. So I usually counsel and say DMPA, how it can affect your weight is that it's an appetite stimulant. So for people who are already cognizant of their weight, who are watching their weight, watching the what they eat, and exercising regularly, it should not be a major issue for them. However, what we know is weight gain is multifactorial. And so research is hard to interpret the data that's being presented just because people will gain weight over time, irrespective of contraception use. So whether there is poor causation in this situation. Obviously, people who are wheelchair bound because of spinal cord injury, they already have challenges of weight gain, and any potential weight gain can make patient transfers and mobility assistance a challenge. So that is something to be discussed with patients. Progestin IUDs, there's 2 varieties. There is the Kyleena IUD, which is 9.5 milligrams, and then the Mirena IUD, which is 52 milligrams, both of levonorgestrel. Their mechanism of action is through change in the cervical mucus, so it does not prevent ovulation. So pros, it's very low maintenance. It's highly efficacious, probably the most in conjunction with the implant being the most efficacious for contraception use. It's long duration, it's good for 5 years, and then there's a non-contraceptive benefits, right? So we use it in the setting of people with dysmenorrhea, with heavy menstrual bleeding. We use it as a prevention and as a treatment for endometrial hyperplasia. So there's a lot of benefit to the use of the IUD. There's no increased risk of VTEs. I use this very often in patients who are at elevated risk or who has recently had a VTE and need immediate contraception. This can be safely used in this situation. There is no impact on bone mineral density, and there is no risk of drug interactions. In terms of con, it does require pelvic examination, which can be quite a bit of a challenge for especially primary care providers who don't have the facility or like the table that can help transfer patients or the mechanisms to help transfer patients who are immobilized. There is a risk of autonomic dysreflexia with insertion. So that's only if patients who have a spinal cord injury higher than T6. So that is something to be cognizant of when you are discussing insertion. Something to be mindful of when discussing use of the IUD in this patient population. Irregular bleeding pattern with initiation is something I always discuss with the patients. It can be anywhere from spotting every single day to irregular bleeding pattern to amenorrhea. Data shows that amenorrhea rate is about 40 to 50% at 6 months of use, and it increases the longer the patient uses it. So it's a very high amenorrhea rate. High risk of PID with initiation. And it can be exacerbated in this Asian population because they are already at a higher risk of urinary infections, and their lack of ability to sense any sort of pelvic infection can make them be more prone to more severe pelvic inflammatory presentations. So that's something to be mindful of when discussing the use of this patients. There's always going to be a risk of expulsion or perforation or malpositioning with IUD insertion. And then the lack of sensation. So you may choose to do an ultrasound after insertion to make sure there's no risk of malposition or perforation, because some patients may not tell you about the pains or the cramping or such because the lack of sensory. Risk of ectopic pregnancy with failure of device. So the risk of pregnancy is about 1 in 10,000 with an IUD. However, when individuals become pregnant with an IUD, they're at an elevated risk of having an ectopic pregnancy. So you need to tell patients about the other signs and symptoms of pregnancy, breast tenderness, nausea and vomiting, in which it can be impaired in patients because they might not be able to feel malposition. They may not be able to, their amenorrhea may prevent them from, it's a hard thing to detect, right? Copper IUD. So the copper IUD is a little different from the hormonal IUD. The mechanism of action is through a foreign body effect. So there is a sterile inflammatory response that prevents sperm from functioning appropriately. So that's how the copper IUD works. there's a lack of the hormonal benefits that comes with a hormonal IUD. However, it's similar efficacy in terms of pregnancy prevention, and similar risk of insertion with the when you're talking about insertion with the progesterone IUD. However, the additional risk with the copper IUD is going to be increase in menstrual bleeding and more painful, crampier menstrual bleeding. So that's something I always counsel patients on when discussing the difference between the copper and the hormonal IUDs. Next is a newer product to Canada. It's called the etnogestrel subdermal implant. Basically, it's known as Nexplanon. It's about the size of a matchstick and sits underneath the skin of where the deltoid is. Its mechanism of action is through inhibition of ovulation. It's about 4 centimeters long and 2 millimeters wide. The pros would be it's very low maintenance. It's good for 3 years. It's very efficacious. It's probably the most effective form of contraception. You avoid the need for pelvic exam, avoid possibility of autonomic dysreflexia. There's very few absolute contraindications. And then ovarian estradiol synthesis is preserved. So I'll talk about that in the next slide about what that means. There's non-contraceptive benefits. So reduction in dysmenorrhea and reduction in heavy menstrual bleeding. I use the implant off-label in this situation for women who have heavy menstrual bleeding or dysmenorrhea. It's an off-label use. So I typically don't use the implant unless the patient doesn't want to try anything else or can't tolerate anything else, just because it hasn't really been studied for dysmenorrhea or heavy menstrual bleeding. There is no increased risk of VTE. And then cons is it's costly. It's not going to be covered by OHIP or ODSP, and there's complications from insertion of the implant itself. Abnormal changes in bleeding pattern as well, and it can occur. So usually the clinical trial shows that 50% of patients have improvement in their bleeding. So I usually quote amenorrhea about 20%, and then 30% may have less of the bleeding. So still, it's less amenorrhea compared to something like the IUD or the Depo-Provera. So I mentioned this. So the implant does not inhibit ovarian estradiol production. So there's really, from the clinical trial, there is no change in bone mineral density with use of the implant versus a non-hormonal method. So that is a benefit. So you don't see that bone mineral density hit as opposed to Depo-Provera. And the estradiols are at a level where you can still, it's still adequate enough to maintain bone mineral density, which is a good thing. Surgical management, vasectomy, self-injectomy, hysterectomy. So pros, it's going to be it's permanent contraception. Non-contraceptive benefits going to be amenorrhea, dysmenorrhea. So dysmenorrhea in of itself, and there's no other causes like endometriosis is not going to be a treatment for a hysterectomy. Is not going to be a treatment for endometriosis, and self-injectomy is not going to be a treatment for dysmenorrhea, right? So that's kind of the difference. There is going to be a decrease in ovarian endometrial cancer risk. So if you're doing self-injectomy, it reduces the risk of high-grade serous ovarian cancer. It's very efficacious. It's low maintenance. I say discreet, but there is going to be scarring that comes along with any procedure. Cons is irreversible. So we always talk about the risk of regret. When I'm consenting a patient for self-injectomy, there's going to be the operative risk, right? So you have to make sure the patient's the appropriate surgical candidate. Ability of patient to consent. So a patient sometimes patients with cognitive impairment secondary to a traumatic brain injury with a spinal cord injury, you have to be able to consent a patient to have this major procedure done. Regret we talked about, and then a long wait list. Anytime a elective procedure like this, especially times in COVID, has been pushed back quite a bit. So when I talk to patients about self-injectomy, I always offer them an alternative form of contraception because the wait list is just so long right now from elective surgery that they should ideally be on something else. That's a whirlwind. I left a few minutes for questions. So yeah, I'll open it to the floor.
Okay, maybe I'll ask a question. Thanks for the presentation. Very thorough. Contraceptive counseling and also just screening, primary care screening of doing pap smears in this disabled, we know that there isn't equity and there is lower rates of these things done. And we do have a primary care mobility clinic, for our region. Just wondering, in your experience in Kingston, do you do anything to reach out to the population to promote contraceptive counseling and pap smears among women who might have a harder time accessing, as you say, sometimes their regular family doc might not have a table or may not be comfortable, or they may need a lift or something.
Right.
Is there some sort of specific outreach or promotion that you do to help in that regard?
Maybe Dr. Waddington can speak more to this, but we don't do primary care here, so I don't do pap testing as a primary screening tool. So I get referrals for patients who have complicated medical concerns who requires contraception, because I'm more comfortable dealing with that situation, and also I can offer them potentially procedural or operative management in that situation. In terms of promotion and outreach, I think the primary care providers here in the area are pretty knowledgeable that we exist as a contraception clinic who specializes in these challenging patients. So we get a lot of referrals, but in terms of outreach, I don't believe we as a clinic do that. Dr. Waddington, do you have any input?
No, I agree. I don't think we have any specific outreach. It's probably a good idea when I hear you mention it. The other issue that we have in Kingston, which I know is probably true in a lot of places, is just difficulty in accessing primary care for all comers, not just people who are living with spinal cord injury or other disability. And so that can certainly make it challenging, not just for this specifically vulnerable patient population, but for all people. So we do have every fall something that we call a PAP party, where we try to arrange, walk-in PAP testing for people who don't have access to primary care. But I don't think we've ever done anything specifically to reach out to, specific vulnerable populations, with the exception of some. We have done some outreach to like Indigenous populations in our region, but not specifically to people suffering from specific medical considerations. So certainly something to keep in mind. I will definitely take that idea. I don't myself organize the PAP party. It's organized by one of the gynae oncologists, but that might be something when they're planning that event and sort of deciding how to let people know about it, that maybe we should be reaching out to like community organizations or patient advocacy organizations, recognizing that this specific patient population might also be a good target for that kind of outreach activity. So thanks for the suggestion.
Well, thanks for the conversation, because Cancer Care Ontario, or whatever the organization is now, for our region anyway, we were talking about this exact problem of how screening rates, it's inequitable for many populations that you're mentioning, and that we might have to do things differently to really have equity, because I mean the rates speak for themselves, right? And it's something where I think we have to really think about that intentionally.
Well, and as you say, like even just sort of physical barriers to being able to access that care, we do have in our gynecology clinic, for example, more options for, the different tables that we can use, like different examining tables, that type of thing. So it's sort of matching up the people who need that to the resource that's there, and sort of figuring out how do we help people to navigate that. So that's really good. It's certainly some food for thought for us. I am seeing in the chat a question about if there's any patient education materials that cover this content. And I will address that unless, Yang, if you have any other suggestions, but probably the two best options in Canada that offer information around contraception are the two websites that are run by the Society of Obstetricians and Gynecologists of Canada. So one of them is called sexandu.ca. It's spelled SEXANDU, like the letter U, .ca. That has all kinds of information about contraception as well as other sexual health areas. And then it's a plan.ca, which is just as it sounds, is sort of an interactive contraceptive selection tool that asks patients a little bit about themselves and sort of what their priorities are in terms of contraception, and helps to guide them to sort of what would be maybe a top 3 options for that person. I don't think there's anything specific to contraception or sexuality specific to the spinal cord injury population or other patient populations who suffer from disability. But that might be a suggestion that we could bring to the SOGC, that maybe there should be, a more specific page as part of those websites for that. But definitely, those are good places to go for some general information about things like mechanisms of action, indications, contraindications, pros and cons, similar to what Yang has gone through in his presentation. Yeah, just a comment in the chat for sure, that it's very difficult to get proper care as a woman living with spinal cord injury, and that you have to advocate a lot for yourself and do your own research. And I mean, I think that is an unfortunate reality that people are living with, that they are having to advocate for themselves, and it's hard to sort of find those advocates within the system to help make things a little bit easier. So thank you for sharing that. I'm assuming that's coming from somebody's own experience. We have a few more minutes. Any other questions?
Yeah, a great presentation. I did just, you touched on some excellent points there. When we're dealing with this patient population, there's always some concern about using the combined oral contraceptive pills, in particular with the blood clots or VTE. And there's been a lot of controversy. I mean, there's been some resources that have said in the past, like never use an IUD in a person who doesn't have good sensation, in the pelvic area. Of course we do, but there's also this concern with this, if they were to have problems, would they feel it and that sort of thing. So great that you touched on those things. The one question I would have, and you talked about the blood clot or VTE risk. Do you have a threshold to that? So for example, if somebody had a spinal cord injury and in their acute phase of treatment, when they were particularly more immobile, they'd had their blood clot, and haven't had one since, you'd be okay using a combined pill, or would you never, or, do you have a sense with that?
Yang, I'll take a crack at that and then you can add anything. When we sort of talk about clinical practice guidelines, like once somebody has had a VTE in any context, that is sort of automatically makes that a category 4 or an absolute contraindication for combined hormonal methods. But as Yang was speaking about in his presentation, the highest risk time for somebody is actually when they're pregnant. And so sometimes we have to look at things a little bit with a harm reduction approach and say, are they better off to be on, for example, a low estrogen dose combined method that's preventing pregnancy, rather than sending them home to a situation where they may, be at high risk of pregnancy, which is going to be their highest risk time for VTE. So sometimes there's a little bit of discussion that has to go around that, but technically it is considered always an absolute contraindication, regardless of the context in which somebody's had a VTE experience. Having said that, expert opinion would say that if somebody has had a VTE or some other reason why they're on lifetime anticoagulation, so for example, if somebody has a mechanical heart valve or something like that and they're going to be anticoagulated their whole life, then it is okay to use combined hormonal contraceptives. So there may be specific situations where somebody's had a VTE and for whatever reason, the plan is for them to stay on lifelong anticoagulation. And in that context, it's not actually contraindicated. So it's a little bit of a complex problem because, at the end of the day, sending somebody home on something that's not effective and puts them at risk of pregnancy is probably riskier overall. But sometimes you have to just really go through what are the pros and cons and risks of all of them, and just pick the one that's the least risky, because all of them may carry some degree of risk or reason why they're not tolerated or not acceptable to somebody. So it's kind of a long-winded answer. Yang, do you have anything that you would add to that?
I would agree wholeheartedly. If that's the only method that would work, and if the risk of pregnancy is just so high up there, then you need to have a pretty thorough discussion with the patient about what are the benefits and risk of using this method. And if that's the only way agreeable and they're at high risk of pregnancy. But there's no easy answer. And I think Dr. Waddington and I have this discussion all the time, and it's quite challenging.
Great, thanks. We have maybe time for one more question if there is any. Okay, otherwise maybe then I'll do a bit of a wrap up there. I want to thank Dr. Wang and Dr. Waddington for a great presentation and for joining us. It was greatly appreciated. I also want to thank everybody who's attended the webinar and has attended our previous webinars. So as Joe had mentioned, we do plan to continue them on in the new year. So have a look out for, we're looking at January for an allied health approach to musculoskeletal pain. And then you'll get some updates. This webinar was recorded. You would find it on our Mobility Clinic website if you go to mobilityclinic.ca in the next little while, and all the previous ones are found there. And aside from that, I just want to hope everybody has a great rest of the year, and a happy new year when we end up seeing you in the new year, which we hope is much more positive and gets much better. So thanks, everybody.
Thanks for the invitation.
Thanks again.